and welcome back to the OI Clinic and Bone Health Town Hall. We're thrilled to have you with us this evening. This has been a wonderful project of the OI Foundation. I am not able to change slides. We have a wonderful agenda tonight, which hopefully everyone has seen in the email, but we're covering, as always, a broad number of topics that are critical to our patients. But before we jump into that, I do want to just bring you up to date on some other things that are going on. Our tele-echo topics that are upcoming in December, the impact of monoclonal gammopathies on bone health with Matt Drake. And then Michael White will be back with us in January. Please note that that's the second Tuesday, because I don't think many of you are going to want to join me on New Year's Day. So that'll be special, Camaraderie-Engelmann disease. And then we're bringing back Grace Loudon-Meyer, talking about OPPG and skeletal dysplasias in the plain community. So a wide variety of intriguing topics. Next slide. As you know, we love to do deep dives. And I urge you to look at the title, Scientific Symposium, the Meloriostosis. What is very exciting is how that disorder is now actually at least 3 different disorders. And we'll have Michael White again, Tim Bhattacharya, and Matt Greenblatt speaking about incredible advances in diagnosing and hopefully managing that disorder. Next slide. And we have gone back to old-fashioned meeting in person in Washington, D.C., and we've initiated a metabolic and rare bone disease club. If you're in our area, we urge you to come and have supper with us, but also recognize that with the wonders of Zoom, you're also welcome to join us virtually. The talk will begin right on time at 7:30. We get together at 6:30, announcements at 7:15, talk at 7:30. So the virtual part will be at 7:30. Now, let me turn this over to the good Kenna, who will take us into the next part of our evening.
Thank you. So my name is Kenna. For those that don't know me, I'm the manager of health education at the OI Foundation. And I just want to take a few moments to talk about some of our resources that may be of value to your patients or yourself. The first program I want to discuss is the OIF National Conference. This event occurs every other year and is the largest informational and social gathering of individuals and families living with OI. The 3-day meeting includes medical informational sessions led by OI experts from around the world and offers networking opportunities to help build long-term support systems that last long beyond the conference. Another great resource at these meetings is that attendees can sign up for up to 3 different one-on-one medical consultations with OI experts to ask questions about their OI. The next national conference will be this upcoming summer from July 23rd through 25th in Orlando, Florida, and registration for that is currently available and open. To help reduce the financial costs, the OIF offers several assistance programs. The first is the Kendall Casper Conference Scholarship, which covers conference registration and 3 nights at the conference hotel. The next one is the Jeannie Coleman Impact Grant, which this one can help with the cost of travel, hotel, and registration. And then for participants of the National Unbreakable Spirit Walk and Wheel, they can earn a free full registration for every $1,000 that their team raises. And I really want to stress that if you have patients that are interested in attending but are concerned about the financial cost, please encourage them to apply for these financial assistance programs because historically the OIF has covered everyone who's applied. So we really want to make sure that financial burdens are not the reason that people don't attend. And those scholarships will be available in early 2026. The next program I want to discuss is the OIF Regional Conferences. These events include sessions and discussions on understanding and living with OI. The OIF hosts around 3 to 4 regional conferences a year, and the goal is to connect people with the medical professionals who are OI experts in their area, as well as an opportunity to meet other OI community members in their area to build a support network. I also want to mention that there's been some updates to the OIF support program, and some of those updates are going to include that it will have the following components now. There'll be quarterly educational and topic-focused presentations that will be led by professionals or community members on various topics of interest. We will be hosting affinity support group meetings, the first one which will be held December 11th at 8 p.m., and this will be a Zoom meeting that will include breakout rooms for women with OI, men with OI, young adults with OI, parents of children with OI, and aging with OI. The OIF also maintains a list of state-based contacts on our website. These contacts are volunteers who are willing to connect directly with OI community members in their respective states to offer support. And finally, we are going to continue to host events during Awareness Week. We will be hosting 3 events that will include educational, support, and social components. And then this year, the OIF updated our website to make it easier for community members and medical professionals to find information. One of those updates was the OIF Information Library, which now includes fact sheets, toolkits, and video resources covering many aspects of understanding and living with OI. One of the most comprehensive resources that we do have is the OIF's published toolkits that support individuals and families across different stages of life. The Navigating a New Diagnosis Toolkit is designed for parents and medical professionals. It includes up-to-date information to support families through prenatal planning, through bringing their baby home. It also includes a section intended for physicians who may not be familiar with OI. The Adult Health Toolkit provides information for adults with OI, their families, and their healthcare providers. It covers a wide range of adult health topics and can be a helpful resource to share with providers who may not have experience treating adults with OI. These 2 toolkits are currently available online and in print in English, Spanish, and French. And if you'd like hard copies, you can email us at bonelink@oif.org. I'm also excited to announce that the OIF is about to release a new toolkit, the School Age Toolkit, which will be released in the first week of December, and I'm going to talk about that more here in a couple slides. Now, as you all know, research is essential to improving our understanding and treatment options for rare diseases like OI. However, because OI is a rare disease, researchers may struggle to find enough participants to make the data meaningful. To help address this, the OIF encourages adults with OI and parents of children with OI to join the OI registry. This database connects participants who are interested in participating in research with upcoming studies and online surveys. And I encourage you to let your patients know about this database if they're interested in participating in research, and let them know that they can register for it on the OIF's website. Another way that we work to keep the community aware of current studies is by maintaining a list directly on our website so that community members can stay informed about opportunities that may be of interest to them. We also keep the community up to date on research by maintaining a list of published research articles on OI, and these articles cover a wide range of topics relevant to individuals and families with OI. Next, I want to highlight the Jeannie Coleman Impact Grant Program a little more. This program is offered annually through the Children's Brittle Bone Foundation and the OIF. This program provides direct support to individuals, families, for products and services that will greatly improve their quality of life. Past awards have included wheelchairs, orthotics, hearing aids, modified vans, ramps, laptops, and as I mentioned, support for attending the national conference, as well as other services and items. Another opportunity I want to let you know about is the Cranston College Scholarship Program, in case you're seeing patients that are about to go to or are currently in college. This scholarship was created in honor of OI community member Edward D. Cranston. This scholarship supports students with OI who are applying to or enrolled in college or university. Applicants must show a financial need, be committed to full-time enrollment, and provide proof of that enrollment. And more information can be found on our website, and the next cycle for applications will open in 2026. And lastly, I want to encourage you, if you've not done so already, to join the OIF medical professional email list. Once you join this list, you'll receive regular updates from the OIF, including monthly e-newsletters, the quarterly medical professional e-newsletter, and updates on events. Now I'd like to shift into discussing the OIF's new resource, the School Age Toolkit. As medical professionals caring for children and teens with OI, you play a central role in their health, safety, and overall well-being. And because of that, I'm excited to share what this new resource includes and how it can support the families that you work with. The School Age Toolkit is a medically verified, comprehensive guide that's designed for families, caregivers, schools, community programs, and medical professionals who support children ages 3 to 18. These years come with huge social, academic, and developmental milestones, which often require families to educate, advocate, and coordinate across different settings. Therefore, we wanted to create a toolkit that could be a one-stop, easy-to-navigate resource to help families think through their child's health and school life, social life, safety, and independence. It offers shared language, practical tools, and printable materials that families can use to collaborate effectively with others. Before I walk through the sections, I want to make one note. As you all know, OI is highly variable, and every individual and family is unique. Therefore, this toolkit is not meant to provide individualized medical recommendations. Instead, it offers medically verified general information to help families understand key topics, prepare for conversations, and confidently participate in decision making across different settings. Families can reference this toolkit when they're navigating health topics, school decisions, activities, safety planning, independence, and more. It's also designed to be a resource that can easily be shared with people who are unfamiliar with OI. And throughout the toolkit, we do reinforce the importance of working with their care teams to make those individualized medical decisions. Now, this toolkit is organized into 8 major sections, and I will walk through those sections. But again, I want to note that each section is meant to help families think through options, prepare for discussions, and explore strategies to navigate different environments. The first major section focuses on health and OI. Even though many families are connected to multidisciplinary clinics, we wanted to provide a clear, accessible overview, especially for those who do not have easy access to OI specialists. This section covers early intervention services such as PT, OT, orthopedics, medication, audiology, and more. There's lifestyle considerations such as sleep, hydration, physical activity, scheduling important health checkups, and more. There's also information on mobility and adaptive equipment, pain management strategies for both acute and chronic, preparing for surgeries, including what to expect, post-operative care, and coordinating with the school. There's mental health and social wellness information, and information on transitioning from pediatric to adult care with suggested steps to help children prepare at different ages. And again, the goal of this section is not to provide treatment recommendations. Instead, this section helps families understand common health topics, prepare for appointments, recognize what providers may be involved in their child's care, and partner more confidently with their healthcare teams. The next section focuses on daycare and before and after school programs, which is a question we receive a lot of inquiries on. This section helps families think through how to choose and prepare for childcare. It includes information on ADA and disability rights, key safety and accessibility considerations, questions to ask when selecting a program, tips for communicating with and training staff, guidance on what to consider when developing an individualized care plan, information on safe handling and toileting support, and creating emergency and fracture response plans. The education section helps families understand school systems and prepare for discussions with their educational teams. It includes types of school settings, special services such as 504 plans, IEPs, and related accommodations, tips for transitioning to a new school, school emergency and fracture response plans, planning for life after high school. And then the next section, the OIF recognizes how important social and recreational activities can be for children with OI. This section helps families think through inclusive participation, risk awareness, and communicating with activity staff. It covers how to assess activities, examples of activities and considerations for those activities, and safe and emergency planning. Another core section focuses on advocacy, which is a critical skill for long-term independence and emotional resilience. This section includes information on the importance of building self-determination, communication, and decision-making skills, advocacy strategies for parents and caregivers, ways adults can model and teach advocacy, and approaches for children and teens to practice these skills at different ages. And then similar to the Adult Health Toolkit, this section includes fillable forms that families can share with their care teams. It also walks families on how to compile their child's health information, including medical history, legal documents, orthotic and equipment documentation, and school/work accommodations. And the fillable forms include a basic health history tracker, orthopedic and bone density trackers, pulmonary and cardiovascular trackers, and medical and surgical history trackers. And then the toolkit concludes with a robust resource section, which includes OIF resources for medical professionals and community members, sample school letters for mild and for moderate/severe OI, fillable emergency and fracture response forms, a handle with care poster, employment rights guidance for parents, self-care suggestions for family, an age-appropriate glossary of common OI-related terms, and a general glossary of terms used throughout the toolkit. And as you can see, this toolkit covers a wide range of topics from both health to social-related aspects. And this is to help empower families and those caring with children with OI. And really the goal of this toolkit is to strengthen collaboration and support whole child well-being throughout their school years. And as I mentioned, this toolkit's going to be released the first week of December. And when it's released, it will be available electronically on the OIF's website. And we'll have physical copies also, which you can request by emailing us at bonelink@oif.org. And if your clinic or practice would like those physical copies, please feel free to email us and let us know how many you would like. And we can get those shipped out to you as soon as it's released. And then lastly, before I finish, I would like to thank everyone who contributed to this project, including the OI clinic teams at Nemours Children's Hospital in Delaware and Children's Nebraska, as well as the OIF's Medical Advisory Council, Board of Directors, and community volunteers. Their expertise and experience made this resource possible. And finally, I just want to thank everyone for your attendance tonight and for your continued care and commitment to your patients with OI.
Wow. Thank you so much, Kenna. Great hard work. And I don't know how many folks on the call have been using the toolkits, but they have been spectacular. My parents are beyond grateful. So it will be great to have yet another toolkit to hand out. And the foundation, by the way, folks, is wonderful about sending them to you. I do find it's not as helpful to send people to the website to start. They really need to have something to hold in their hands, look at, and ask questions about. But hats off, really big job. All righty. Now we're going to move on for our planned education. Not that you weren't educational, Kenna, but with our the rest of our program, we have three very important topics, and we're going to begin with physical therapy. And I'm so glad to recognize welcome Francis Barada Ziska. I don't know about you, but I frequently have that. How the heck do I explain to the PT what I need? And it because most of my patients don't live close to my clinic, and they're not going to be able to use my hospital's resources. So we're going to buckle down and get some good tips right now. So Francis, thank you so very much for being with us. Francis comes from the hospital for special surgery in New York and follows a ton of kids there. All righty, can we share the screen for Francis?
Do we have it? Do you want me to reshare?
Yes.
There you are. Great.
Okay. Is it up?
Not yet.
Do you have it?
No, you will share it directly from
Share it
yours.
again?
Yeah.
Okay, I'll do it again. Okay,
Terrific. Yep.
can see it now?
Yep.
Yeah.
And we just need you to
Click
go to presentation.
Yeah. Click the slideshow.
Yep. Oops. Don't want to go. There we go. All right. Dr. Tosi and Tracy, thank you for inviting me tonight and asking me to speak about what physical therapists do with managing children and adults with OI across the lifespan. It's been a nice relationship of all these years. I started working with people with OI with Dr. Leon Root many years ago. I don't have any disclosures. And at the end of my talk, I hope that people will be able to categorize two rationales for why they should refer to PT for individuals with OI, that you'll understand the principles of when to refer an individual to OI with OI to PT, and also that you'll have developed an understanding of what our role as a PT is in the management of the individual with OI. So we know that osteogenesis imperfecta is a diagnosis and is really a spectrum of disorders. It involves multiple systems, the ears, not only the bones, the ears, the eyes, the GI system, which can all impact a person's mobility and how they can care for themselves. And also that PTs will work with people with OI during acute fracture episodes, as well as non-acute fracture chronic episodes. So like if they have pain or if they're having mobility issues, and that PTs generally will work, let me go back one, will create individualized family patient and patient-centered goals and exercise programs. The goals of PT for therapeutic management is really to promote that person's growth and mobility and functional independence throughout their lifespan. It's to provide them with an exercise program that helps them improve bone mass and muscle strength so that they will have mobility without issue or less issues with mobility. We try to educate families with young children with OI in safe handling and positioning and the importance of positioning children in different positions. We try to work with people to improve their pain if they're having painful episodes that are interfering with their daily activities. And again, it's not just the physical therapist, it's also multidisciplinary care throughout the lifespan. So there may be a time in the person with OI's life that a PT will be important, but there may also be a time when an OT might be important, or a speech language pathologist or a feeding expert might be important. And so we help the families to be more realistic about their goals and what is like paramount at the moment, to like focus on the present, but also plan for what's coming ahead. And so PTs, what our job is, we really want to try to break this cycle of OI that happens when there's a fracture and the person experiences pain and immobilization. They experience weakness with immobilization. They can have decreased bone mass because of immobilization, and this can set them up for an increased risk for fracture. So the PTs get in there, and we try to help the patients move safely. We try to get them strong and keep them strong while they're healing, so that we can mitigate decreased bone mass and increased risk for fracture, and also manifesting pain. So when should someone refer to a PT? Really, we like to see that child when that diagnosis is given. So we'll see the child as young as 1 to 2 months old. And especially if the child has a moderate to severe diagnosis of OI, that would be helpful to help educate the person on ways to move safely and how to keep an active lifestyle so that they can have overall well-being as they age. And also, after a fracture, to learn how to maybe use an assistive device to get around safely, and again, to mitigate those secondary complications due to immobilization that might be necessary after a fracture or surgery. We work with infants as young as 1 to 2 months old, and we try to educate the family on how to mobilize the child, but also how to handle the child safely, and also to model that the child can assume certain positions that maybe the family is afraid to put the baby in, and also to do skin to skin nurturing, not just some parents carry the baby in a container, and so we really try to educate the family on that skin to skin nurturing. And we look for any delays in gross motor skills, or if there are new mobility challenges due to fracture or pain or decreased activity level. So here is a collage of something that we would work with the family. And here you see we work with the child. This child's probably around 5 months old, and we're working with the mom on how to kind of corral the extremities so that they're not dangling, and that would decrease the risk of a fracture or the arm getting caught in something. So to kind of corral the arm, not to bind the arm, but to just corral it during a feeding so that we reduce the risk of fracture. Also to keep the head in midline as we would with any child, so that really emphasizes that midline orientation for the babies as they grow. And we also give the parents confidence that the babies can reach for their legs, and that if the baby is initiating the movement, then it's okay to kind of see where it goes and not to be afraid that every movement is going to cause a fracture. And also, sometimes families are afraid to put babies with OI on their tummies. But if the baby is already showing us that they are grabbing their toes, or they are starting to roll to their side back and forth, and they're also getting to their tummy, then it's safe to kind of monitor them as they play on their tummy. And then here we also work with children on when they're first going to come up to sit. So we always tell parents, we don't really advocate putting babies in containers to sit, but when the baby is showing an interest to sit, like trying to pull up to sit, or even coming off the parent's lap to come up to stand. So then we say we follow the baby's lead, and we will go and give them that guided motion to come to stand or to sit in small increments. And so this baby during a session was sitting on the mom's lap, and then started to kind of reach forward. So right away, I put the cube chair in front of him, and mom said this was the first time he took weight on his feet. And so it's, again, I guided the mom to say that as he comes up, just pull him up so that he's not taking full weight on his legs and feet, and just let him kind of play with the movement first. And then as he's more confident, we can let him have more weight on his arms and legs. And this is a child who was born with arm and leg fractures. So, and he's still an infant here. So, he's showing us that he's ready to do it. We don't, as a PT, we don't impose the movement on the child until they show us that they are interested in it. And here again, the importance of varying the postures of children so that they don't develop malalignments or contractures. Sometimes the babies are so weak when they're born that their legs turn out, and then they have a hard time turning their legs in, and that can affect the muscles more at the hips. So we like to show the parents how to optimize alignment during various postures. And here again is this little boy that is playing on his tummy and is exploring this water-based activity. This is during one of his first sitting activities, and I corral the balls around him so that he doesn't have to overflex over his hips, and which may put too much strain on the femur. So showing the mom how she could set up the toy environment at home to make it a safe experience for him as he gets better at sitting. And here is the same child who, when he came to us, had a little bit of a flat head, plagiocephaly. And his mom wanted to know, could she get cranial orthosis for him? And I said, well, you'll have to check with the doctor. I said, but if he's cleared by the doctor and the neurologist, you could go for a consult. And she did. And she's very pleased that he had the helmet, and he was able to, it didn't hold him back from sitting or creeping or anything like that. What's the rationale for PT with people with OI in childhood? So again, we want to really maintain that mobility and strength and functional independence. We know that as children age and they become to those preteen and teenage years, sometimes the mobility kind of gets less, and they're more on their devices, their screens, rather than wanting to do exercise or move around. So we try to educate the child at this point how important it is to maintain a level of mobility and strength so that they can continue to be as independent as they can. And here's a young lady who lived on a third floor walk-up apartment, and it was very important for her to maintain her walking ability. And she has a severe type of OI, multiple fractures throughout her lifetime. And here she's about 14, and she had also had spine surgery. But every session, we would practice walking up the stairs with crutches. She would also strengthen the same muscle, the large muscle systems of the legs, walking up and down this step with her walker so that she could exercise the glutes and the quads and the gastrocs. And she needed to do that. So the PT referral can include mobility training for particular environments. In her case, it's for stairs, also transfer training. And also we know that having good balance helps to reduce the risk of falling. So we do a lot of balance training from a very young age. So here I have this young girl taking off her sock while she's standing with support of the wall, practicing standing on one leg. So what are the key referral triggers? We like to get a referral when the child might be experiencing recurrent fractures or poor healing, and this also goes for adults. If their status post-surgery, they would need rehabilitation to get transfer training and maybe mobility training. If the child is showing developmental delays or delays with their motor milestones. So if someone comes into the office and they're 4 years old and they're still wearing a diaper and they're not transferring on their own, or the parents are still taking them in and out of the stroller, it's a good idea maybe to send them for physical therapy or occupational therapy for some education and some training in those areas, knowing that soon the child is going to be in some type of a school setting, and it takes a while to learn these skills and develop the strength and coordination for it. So that would be some time to send the child to PT or OT. And anytime the person needs education with a mobility aid or adaptive equipment. So in the case of someone who might be independent walking with a walker but needs to use a crutch, maybe in their kitchen that's maybe too small, or their bathroom, or if they need to do a step to get into a restaurant and they're interested in that, that's the time that they can come for a short course of PT also and learn how to use that mobility aid safely. And also, if the child is, or the parents are interested in the child participating in certain school activities, and they can come in and we can work on the components of the task to get them to be able to participate in those activities. I had one child that wanted to participate after school, but he couldn't get busing. The bus was already gone, so he had to figure out his own transportation. So that included like ordering his Uber and also getting in and out of a car rather than getting up and down a bus. So that was an important episode of care for that child. So what do we look for in a PT specific referral? Definitely the diagnosis, not only the main diagnosis of OI and the type, but also if there's a recent fracture, we should have an ICD code for that. If the patient is experiencing pain that's impacting their mobility or their self-care, if they've had any surgeries, or if there are any particular areas that you want us to focus on because of contractures or weakness. Also, if the patient is saying, well, I used to walk a block and now I can't walk anymore. So what would the goal be? Independent walking, community distances. Fine. Patient, the child needs to go to school and would like to transfer on and off the toilet. So improve transfers for toileting. So we do that. And we're happy to work with the family because then that helps the child set them up for more success in school and also to save their energy for what they're there for, which is education and socialization with their peers. And also, if there's any restrictions or precautions that the doctor wants to highlight for us, such as the weight-bearing status, and if there's any activities that you would prefer that the person doesn't do at this time. So the PT certainly will assess for mobility and muscle strength and balance and any need for adaptive equipment, and that's ongoing as the child grows and evolves. We'd like to help them develop safe exercise programs that work with their lifestyle. So we don't recommend that everyone go to a gym because a lot of time the gym equipment isn't sized well for people with OI because they tend to have short stature, but also it's not maybe safe for some of them to attend a big crowded gym. So we try to educate them on the different types of exercise environments that maybe they would like to participate in, maybe like a small group class that works with resistive exercises, but in a more controlled manner and not so crowded. We talk with them about gradual weight bearing and incorporating low impact activities like aquatics and cycling into their exercise programs. We also assess for collaboration with OT and speech. So one of my infant children that came to me, the mother was just telling me about an appointment she was having. The well baby visit was coming up. I think it was his 4-month visit. And if he hadn't gained enough weight, they were going to talk to her about getting him a feeding tube. And he was about 2.5 or 3 months old at the time. And so we had some time. And I said, would you like to speak to our feeding therapist? Maybe she can look and see how he's eating and she can give you some tips. And so I reached out to mother was interested. So I reached out to the doctor, the referring doctor, and I explained, and they put a referral in for the feeding therapist. And sure enough, they developed a nice rapport and he was able to maximize his nutritional intake so that at his 4 month he didn't really need the GI tube, which was mother was very pleased. And then from that, when he graduated from the feeding therapist after eating solids, then they recommended speech language pathology for articulation and communication, because being able to communicate and delegate for yourself is probably one of the most important things for all children to do, especially for children with OI. So that's always paramount. So that he was working with the speech language pathologist for a while, and he's graduated by now. So in every exercise program, no matter if you have OI or you don't, throughout the lifespan, there should always be a component of aerobic training, strengthening, flexibility, and if there's a specific sport or activity that the person is interested in doing, some type of specific training. And sometimes it's nice to have that guidance with the physical therapist that could kind of help you see how to build that into your daily activities. Um, all movements should definitely include core and trunk stabilization so that you don't hurt your low back or your neck or your shoulders. And also always mindful of your alignment, your posture, and your body mechanics when you're working. So this young girl with the bowl over her head, you can see I have mirrors behind her, but so we use the mirrors. I always ask her, you feel your head, your hands coming over your head, you're balancing even on your butt. And so that's really important from a very young age to have the child have that awareness as they're exercising so that they could be mindful of their alignment and putting the muscles in the most efficient alignment with the bones for that movement. And really, weight bearing activities are really a must with people with OI so that they can consistently improve their bone density and also to really optimize adherence to home exercise programs. I talk with the families about what their daily routines are, and we try to minimize how many individual exercises we give them, and we uh, try to integrate some of the activities into things they need to do every day. So you see this young girl here, she's doing her hamstring stretch while she's putting on her shoes and her braces. So again, PTs, when working with people with OI, ultimately, we really want to support their independence and show them how to safely exercise. We want to help them learn how to communicate effectively and always, to learn that if people don't, if you haven't asked for help, people don't have to help you, and you need to learn how to explain that to people so that they don't hurt you or cause a fracture inadvertently. Communication is paramount. Learning how to take care of yourself is second, and mobility is really third. When I worked with Dr. Root at Hospital for Special Surgery, who started the OI clinic at HSS, he always said communication is very important, the most important thing to teach children, then how to take care of themselves, and then mobility. And this was a very insightful thing I thought he would say, because from an orthopedic surgeon who was interested in getting people walking and moving again, to put communication and ADLs first, I always held that with me as a very important teaching. And really, ultimately, it's for the play and activity and participation that the children want to do. We want to get them strong so they could get moving and go do what they want to do. Here is this young boy with he has a type 3 OI, and he's working with a speech language pathologist, working on his expressive and receptive language skills. And here is this young lady again, try to integrate her flexibility exercises when she gets dressed in the morning before she gets off of bed, and then she gets up and going, and then putting on and off her braces. Again, PT, we don't work alone. We work in a team. The team includes the infant, the family, the caregiver. Again, we can refer to an early intervention coordinator and other specialists. These are some resources that Kenna already had mentioned. And again, it's an individualized plan for that person at that time in their life. It may change in a year. It may change in 2 years. It may change when they need to go, when they turn 18 and they becoming young adults and want more independent living. So that's why it's individualized, and it's context specific. The type of OI affects the progression. And again, communication, independence with ADLs, mobility, and really working with them to understand that it's about lifelong fitness. Thank you so much.
Princess, that was just great. And I think, in ortho, we say movement is life. And I think with this population, this community, it is the absolute mantra we have to maintain. That's for sure. So this was just great. We're open for questions. I think we're a small enough group if you just want to unmute if you have a question. Don't be afraid. I'll start with one. So as a therapist, we're in a busy clinic. We've got 30 seconds to write that PT order. Independent mobility, transfers. Just think about the key words that will help me get what my patient needs.
Sure. If they're having trouble standing up from a chair, transfer training. If they used to walk and they're not walking now since they've had a fracture and it's been already 12, 16 weeks, ambulation training. And you don't even have to worry about putting down the assistive device if they don't know what they need at the moment, right? Because they haven't walked in a while. You can let the PT assess that and then refer and then reach back out to you. Usually, what the doctor will do is they'll put in a PT order for ambulation training and then a separate order for gait training, and they'll put assistive device based on PT recommendation. And that way I don't have to go back and forth. And then I just send the doctor a little note. This is what we did. It's all in the note.
One of the problems I find is insurance, and insurance is willing to pay for an emergency or, an episode, post-fracture, that sort of thing. But our patients need therapy every day, always. Any thoughts on fighting that battle and ensuring that the patients can get ongoing care?
So one of the things, you're right, insurance is not going to pay for just everyday PT. But what we do is, and the patients don't want to stay married to the PT, honestly. They want to have their life. So we do episodes. So maybe we'll do like 8 to 12 weeks and then go and see how you do with everything we did. And then if you think you need a tune up in the spring, come back. So that's what we'll do. If the family knows they're going to be away for the summer, or it's going to be too busy to do any PT, then those episodes of care might happen once they're settled in school. They'll come and then they'll take a break during the holidays, or vice versa. Sometimes if they have more time during the holidays to come, then they'll come that week that they're off. So we work with the families about that. And that also gives the families license and not to feel guilty that they're not coming to therapy or they're not doing their exercises. Because by the time that episode of care with PT is done, we've already said to them and they've already proven to us that they're moving a little bit more than they were before. So they might be walking a block, or they might be getting out of their chair at home rather than staying in their chair and going from room to room. Because I'll say to them, you walk good enough to walk in the house without your chair while you're using your chair. So those are the things. Or you could sit in any chair. So you don't need to sit in your chair. You put your wheelchair by the door and you can sit in any other chair in your house. So that also encourages them to get up and down a little bit more rather than staying in their chair all day. Does that make sense? I have a gentleman who is an adult who works, and he's he's dependent on his wheelchair for mobility. And I say to him, when you check your emails and your phone messages when you first get in, do you have to sit in your chair? Can you recline a little bit so you stretch out the front of your hips? Because those tend to get tight. And he does. So now he takes those messages out. At lunch, I say, you need to get out of your chair and sit in a different chair. And then you also need to stand just for like 3 minutes after you've eaten. And so that's what we've incorporated: some standing and weight bearing, transferring, and some gentle flexibility without really adding anything to his day. It's within his day.
Great suggestion. Absolutely great. All righty.
I have a question. This is Molly from Chicago.
Hi.
Great.
My question is, we have pretty young kids with more severe type of OI lately being started with a gait trainer. Do you do this? Is this more like when I started 15 years ago working with little children with OI, we were not using gait trainers. What do you think about this?
So if I'm thinking right, the gait trainers are the ones with the saddles that they kind of can sit on.
Yes.
Right. So I just be careful, right? Because I don't know what the status of the pelvis is. So I would just be careful with using the gait trainer. And, for, I don't know, you said younger ones, right? Not older ones, because then we have to be careful of any acetabular problems. So I like the child to show me that they're interested in coming to stand, like that in that picture that I had posted. And then once the child is showing me that, I will stay with them while they walk and I will support them under with a very wide base. If the saddle on the gait trainer can be built such that it's very wide and the pressure can be distributed across both of those ischial tuberosities, then I might try it. But I would have to really know the kid and know like what his fracture history is to know how much I could push him. Does that make sense?
Yeah, it does. And I agree with you. I thank you. That's very helpful.
Okay.
Great. Well, a great session, Francis. I
Thank
really
you.
appreciate you joining us tonight.
I think Dr. Tosi, pardon, Dr. Ayers, did you have a question?
I had a quick one, but I don't want to get off our agenda. I had a question about adults with OI, and it seems that when you're on a search for a physical therapist, that there are sort of types or subtypes of physical therapists as an adult. And it seems sort of trendy that there's some like sports medicine and I just wondered if you had some direction for adults with OI about maybe which type of physical therapy we should look for.
So I would say what it depends on why you're going to the therapist at this time in your life. Is it because you want to, are you having a specific issue? If you're having a shoulder issue, then go to a shoulder therapist. Someone that's, if you're having an issue with mobility, maybe someone who does a little bit more in rehab. But honestly, um, it depends on what you're going for specifically at that time. If it's to get ready for a certain activity that you need to do, like a certain sport or activity, or you need to improve your aerobic capacity, I would say any therapist. But I would say it depends on like what your issue is at this time.
Okay, thank you.
Sure.
Great. Okay, last chance, folks. Oh, all right, and what paying to everyone. Sometimes the children. Here we go. Nope, lost you. Sometimes the children are afraid to stand after lower limb fractures.
Right.
What would be your advice for getting them back? That's a great question. Thank you.
So we take it at their pace. Just like that little boy, his first standing was at the yellow cube chair. And also the young lady who lived on the third floor apartment. Well, both of them had histories of lower extremity fractures and surgeries afterwards. And I take it at their pace because I don't want them to be afraid of me. I want them to know that it's a safe space when they come to PT with me. And if one day they come and all we do is weight shifting forward and back, that's any weight shift is the precursor of a movement. So you have to weight shift forward to kind of get out of your chair, and you have to weight shift sideways to take a step to free up a leg. So if that's what we do for one whole session and the child feels comfortable and we build that rapport, that's what I do. And usually the child will show me when they're ready to get up.
Great. All righty. So we're almost exactly on time. Again, Francis, huge thanks for joining us. And I'm sure that you will be willing to take later questions if people think of something that they wish they had asked. All righty. So moving forward on our agenda tonight, it now gives me great pleasure to introduce and welcome Dr. Jill Simmons, who's coming to us from Vanderbilt University, who'll be talking to us about decision making in the medical management of OI. As someone who's cared for this disorder for longer than I like to admit, the changes have been huge, but I don't think there's always a consensus. So I'll be really interested to see how somebody else does it. So welcome, and can we get Jill's slides now to share? Getting there, great.
Let me get into presentation mode. Which I'd love to be able to do, but okay. All right. Thank you.
Well done.
This is exciting. That was really a great presentation. Thank you, Francis. I learned a lot. I am going to spend a few minutes talking about the medical management of OI and really from my perspective, as well as hopefully some emerging therapies that we may have available to us in the future. Here are my disclosures. So again, we're going to talk about current medical management strategies and then talk about some therapies that are in preclinical or clinical trials that may be future options. So anytime we think about therapies, we have to really start from the very basics from my standpoint and think about what are our goals for management. And that is really what we base all of our assessments of the management on is really, does it help us meet goals that are important to patients and to their families? And so these are the primary goals that I think we have for management of OI in terms of medical management, which would be ideally to decrease fracture incidence, to reduce pain, to promote growth of the children, to preserve mobility and functional independence, which we just spent a lot of time talking about, which was great, and improving quality of life. Of course, it goes without saying that this is a very multidisciplinary specialty, and these and many other people are needed to be on the team for individuals with OI. But remember, of course, there are literally no FDA-approved medical therapies for OI. So every single thing we do is all off-label. So that is important to know. It seems very simple to me that at the very minimum, we need to optimize nutrition. Ironically, even that has not been well studied, but it goes without saying that if you're vitamin D and or calcium deficient, that is sort of a second hit to a bone disorder that already causes bone fragility. And so certainly, we need to be asking our patients about their calcium and other dairy intake, vitamin D, etc. So one of the big questions that we have in this field is when to initiate medical therapy. So no clear guidelines. And for me personally, and I think for many of us in this field, we look at this as it's very dependent on the patient and the disease characteristics of that individual patient. So OI type is important. So the more severe types, which we sort of classically would call 3 and 4s, that is a little easier. I think most of those patients do benefit from some medical therapy. OI type 1 is often much more of a gray area. And then I really start thinking about fracture history, fracture rate, what type of fractures the patients are having, what kind of pain might the patients have. They'll describe it as bone pain. Not sure it's really bone pain, but the generalized pain that often occurs in these patients. The age of the child plays a role, and we'll get a little bit into that too. Comorbid conditions. So our patients also requiring glucocorticoid therapy chronically for lupus or something like that that is even an additional component to adversely affect their bone health. And I put DEXA here as a question because DEXAs are very challenging to interpret in the pediatric population in general. And then you throw in the fact that these patients are typically quite small in stature, particularly the more severe forms of OI, and they may have surgical instrumentation that's been placed into their bones, which makes it really hard to interpret. So I would never make a determination on medical therapy based on DEXA alone, but it may be an important component, at least in following the response to therapy. I promise this won't be painful. I am not a basic scientist. This is going to be very, very simplistic view of bone metabolism. So remember that our bones are a very dynamic organ, and we're always producing new bone tissue and removing old bones. So we have bone production happening from osteoblasts. We have bone resorption happening from osteoclasts, and a lot of interconnectedness between these cells as well as the osteocytes that are sort of the regulators of the whole process. So one of the things that we know is that not only is there a collagen problem in patients with OI, but there's some additional dysregulation of bone homeostasis with somewhat of a decrease in the bone formation process and an increase in the bone resorption process, which makes everything even a little bit worse. And the reason I touch on this is important for why we're thinking about using certain medications. So here are some of the pharmacotherapy options that we have for OI. And I'm going to go through these kind of from top to bottom. For the last 30 years, at least in the pediatric space, almost all we have used is anti-resorptive therapies, and primarily that's been bisphosphonate therapy. In the US, we've primarily been using IV pamidronate or IV zalindronate. And how does that work? It works to decrease bone resorption. So it really decreases that osteoclast activity, therefore building more bone on top of old bone. So increasing perhaps the amount of mineralization that's there, but certainly not normalizing the scaffolding itself. We've been doing this since the mid 90s pretty routinely. And just as a reminder for folks, the very first case report was reported in 87. And then the Montreal group gave us our first systematic study of children with OI, looked at 30 kids between the ages of 3 and 6 with severe OI who'd been treated with pamidronate. And it was really exciting. This is really why we started doing what we do, which is treat with bisphosphonate therapies in patients who have severe OI. But there was a 41% increase in bone density and a decrease in fractures, which has been really exciting. So in the intervening years, there have been a number of studies in the pediatric space that continue to suggest increased bone density, decreased fractures, decreased bone pain, and improved functional status. But keep in mind that really pretty much all of these studies have been observational, relatively small studies. And similarly, in adults, there's also been some studies to demonstrate increased bone mineral density, but a lot of inconclusive data about whether fractures are affected, improvements or not in functional status, and whether there are any changes in pain felt by adults with OI who are treated with bisphosphonates. Again, most of these studies have been observational, and the randomized controlled trials have been relatively small with quite a heterogeneous population. So the most recent large-scale review was a Cochrane review, and that was published almost a decade ago now, looking at bisphosphonate therapy in patients with OI. And sorry, it included 14 clinical trials for a total of only 819 participants, and only 2 of these trials included adult participants, so really primarily pediatric data. And to cut to the chase, the main conclusions were probably oral and IV bisphosphonates will increase bone mineral density in both kids and adults with OI, but really otherwise it's quite unclear whether bisphosphonate treatment consistently decreases fractures, although certainly individual studies do report this independently. And they were really unable to conclude whether bisphosphonates improve pain, growth, or functional mobility, although most of the studies didn't even try to answer this question, so who knows? It really didn't provide the opinion on whether pamidronate versus zalindronate happens to be better. So what do I do? I take this for what it is. I think we all maybe have a little bit of nuances on this when I am deciding when to start therapy. This is an individual discussion with the patient and family. So there are no overriding requirements for this. But certainly if a patient is having fragility fractures, which often is sort of once they get to the second one, is often when I will really highly recommend bisphosphonate therapy in these patients. Some patients I end up treating because their primary component is actually more pain than fractures, and we can see some improvements in pain. And again, I don't typically use bone mineral density by DEXA to make that decision, but it may be playing a role. Which one do I start? I personally tend to start pamidronate in the youngest kids. I note that in the patients who have a primary pain component, they seem to have more relief from pain with bisphosphonates. And I have had older children who have tried to move to zalindronate. They'll have a couple of doses and they beg to go back to pamidronate because they don't feel like it helps their pain as much. Again, never been really well studied. I think many of us anecdotally have discussed this, but that tends to be my approach. There may be that the more frequent infusions that we use in pamidronate may be potentially helpful for that rapidly growing bone in the infancy and toddler time. And maybe there's less calcium problems. Hypocalcemia is certainly a side effect of pamidronate or zalindronate, and it just seems to be slightly more gentle in the pamidronate group. Older kids, usually those who are 3 or above, I tend to start with zolindronate due to it being a shorter infusion, and we'll talk about that. So zolindronate, my personal approach is to give what I would sort of call a half dose the first time, and then 3 months later with a more robust dose. And then I generally treat them every 6 months for several years, monitoring various things, which we'll get to, and then at some point decrease to annual. Pamidronate, I use what I think is lovingly called the Omaha protocol for those who are out there, as opposed to the 3-day Montreal protocol that was the original 3-day three subsequent days that has been what was originally reported. I just find that's really challenging for patients and families out of their day-to-day life, and single-day dosing has demonstrated to be effective with that dosing strategy that how do we monitor bisphosphonate therapy over time? Again, as a point, there's no clear guidelines. That's why we're having this discussion tonight. I tend to get a DEXA every 1 to 2 years, acknowledging that that can be challenging for the reasons we've already talked about. I do monitor bone turnover markers with each infusion with a goal of avoiding oversuppression, just to sort of prevent perhaps some of the problems you can get with hyperdense atypical bone, such as pseudofractures or atypical fractures. But you really have to talk to the patients. And sometimes I alter the frequency, the type, the dosing, et cetera, based on their perception of their pain between doses. So I've had patients who say, we're doing this every 4 months, but I start having significant pain at 3 months and 2 weeks. And I say, okay, let's journal that. If this is real, then let's give it 2 weeks earlier and see if that helps it. I also think there's times of the year that the pain seems to be worse. So I may end up giving dosing slightly more frequently in the winter months where patients may complain about more generalized achiness, and less often in the summer months with sort of a goal of, a consistent dose per kilogram of body weight per year. We decrease the frequency of infusions when appropriate, based on all of this other information. And then in general, I often will try to stop infusions if tolerated when the growth plates close. I throw in this if tolerated because there are some families who call me back begging for another dose or two for pain management. And that can be hard to know what to do with. Okay, I want to talk to you a little bit more, though, about a couple of other options that people are either using off-label or are in studies. And I think the thing that's been that we really need to discuss the most is denosumab. This is an anti-RANK ligand antibody that's a potent anti-resorptive. And there was one retrospective case series in 5 adults with OI. That's it that I can find in the adult literature. Those patients were treated for a median of 18 months and had some improvement in bone mineral density for the most part without fractures. But pediatric trials have been happening lately, and I think some on the call were probably a part of the pharmaceutical sponsored trial that was terminated a few years ago due to hypercalcemia. And I think people who are considering using this off-label need to understand this potential risk. In this trial, 13% or 8 of 60 of the pediatric patients did develop hypercalcemia on 3-month dosing. Within the last year-ish, the Dr. Liu and others from Japan did publish on the largest reported trial to date, which looked at 84 pediatric patients with OI who were treated with 6-month denosumab over a year, so 2 doses effectively, or compared with zolindronate, a single dose of zolindronate. Now, these patients were also treated with calcium, vitamin D, like regular vitamin D, as well as calcitriol. I think to really try to prevent the acute hypocalcemia that can happen immediately after denosumab therapy. And bone mineral density improved in both the denosumab group and the zolindronate group. Those that had some vertebral compression fractures did show some remodeling in both groups, so that's really encouraging. But 31% did have this similar finding that was found in the terminated trial in the in the pharmaceutical sponsored trial in the US, where we had rebound hypercalcemia in again 31% with relatively short duration. So remember, this is sort of a every 6 month injection, and the mean time of onset of hypercalcemia was almost 5 months, and it did appear as early as 3 months in this patient population. So 6 of the patients in the trial did have a hypercalcemic crisis that required hospitalization. This hypercalcemia seems to be more likely in the youngest kids and in those with higher bone resorption markers. Now, encouragingly, you can rescue these folks with a zoledronate infusion and some fluids and stop the supplementation, and hypercalcemia did not recur after 1 year of follow-up. So there's some sort of back and forth in this particular journal. With some commentary after this was reported, and it was noted that they had been on calcium, vitamin D, and calcitriol, and maybe if that had been backed off on earlier, this may not have happened. But I just think it's really important that people are aware that this is a pretty significant consequence that can occur and needs to be followed really closely. Okay, couple more things. So what about anabolic therapies? What about the other side of the coin, if you will? And there are a couple of trials in pediatrics and adults right now that we need to talk about. So sclerostin, again, back to our simplistic version of bone homeostasis, remembering our osteoblasts and our osteoclasts. And how does sclerostin work? Sclerostin overall reduces works to reduce bone production and increase bone resorption. So if we inhibit that, basically we inhibit the inhibitor, we therefore have increase in bone formation and decrease in bone resorption. And so that's how the anti-sclerostin antibody works. So the two active clinical trials of an anti-sclerostin antibody include the setrusumab study, which is now actually completed. We're anxiously awaiting those results. This is a monthly IV infusion that's been occurring over 2 years, and romosozumab study, which is still ongoing. And this is a monthly subcutaneous injection compared with bisphosphonate, and that is a 1 year trial that is still active in a number of sites. These have been reported at ASBMR and other places, so I don't want to belabor too much, knowing that we're limited in time. But the original adult sort of dose finding study of setrusumab did provide some really encouraging information about increased markers of bone formation that occurred rapidly, and was a dose response that you would expect with a higher dose, resulting in higher bone formation, nice improvement over 12 months in bone mineral density, and a decrease in fracture rate. So that therefore led to the phase 3 studies that are going on now in pediatrics. So in about a year ago at ASBMR, we learned about some of the early results from the first 24 subjects in the pediatric and young adult population who were treated with this phase 2-3 study, and saw a really nice increase in bone mineral density and lumbar spine at both 6 months and really quite impressive at 12 months, with an annualized fracture rate that went to 0. Now, do I think that's going to be true over the course of the whole trial? Of course not, but some nice early information. We'll see. Like I said, the data set has literally just been closed, and we'll see what it looks like. What do we know about romosozumab, another anti-sclerostin antibody? Now, this one is already on the market for adult osteoporosis, but this is just being looked at for OI. Single case report that I can find looking at romosozumab in an adult with OI showed some improvement in bone mineral density. The initial phase 1 results of the first 25 patients treated on the romosozumab study in patients with OI did show some increasing bone formation markers and improvements in bone mineral density. It was well tolerated, so this is a phase 3 ongoing study that's looking to enroll ultimately 106 pediatric patients from across the world. What about teriparatide, which is, of course, just basically an analog of parathyroid hormone? This is there's been an 18-month trial of essentially 80 adult patients with OI that did demonstrate increases in lumbar spine, bone mineral density, and total density. Was not powered to assess fracture risk. There is an ongoing adult trial that the baseline results literally were just published within the last month or so, looking at fracture rate after a 2-year course of teriparatide with a single dose of zoledronate compared with standard of care. So it will be interesting to see how that works. Trying to keep my eye on time here. Just a couple more slides about a couple of things that are in preclinical work now. So several groups did report at ASBMR on a really nice combination of a bispecific antibody that looks at it's an inhibitor of Wnt, which therefore works to be sort of pro-resorptive, or Wnt is pro. It increases bone resorption and decreases bone formation. DKK1 does as well, similar to sclerostin. So it really might be a nice idea to look at some combined therapies. There have been some PK studies in non-human primates that were reported at ASBMR as well as healthy volunteers. A couple different groups looked at different mouse models of OI and did demonstrate some improvement. So this may end up being something that's an option for human trials in the future. So that's exciting. And I just wanted to point this out because I thought this was really cool. So vosoritide, for those who are endocrinologists and geneticists on this call, may know that this is a medication that's relatively recently been approved for patients with achondroplasia, and it really has looked to improve the growth. But a couple groups reported on this as well at ASBMR, demonstrating that if you give vosoritide with or without alendronate to a mouse model of OI, it did show a nice decrease in fractures, which is great. Whether or not you were on alendronate, vosoritide may benefit that. But something we haven't seen in any of the other OI type medications is improvement in growth may be a possibility in patients with OI more dramatically on some if you add something like vosoritide. So the long bones did grow better in these mice. And so it's just sort of an interesting question as we think moving forward, could that potentially help with growth in patients with OI? Okay, so that was really quick. Management of OI is a multidisciplinary and multifactorial or does require that. And I think this group knows that quite well. There are no current FDA-approved medical therapies for OI, but I'm really personally quite excited about the fact that, you know, we've had the same thing for 30 years, and now there's a lot of other possibilities being evaluated both in preclinical and clinical trials. And really, I wonder if long-term what we're going to figure out is more personalization of medicine is typically our goal, with individual patients maybe benefiting better from different types of combinations of therapy. But of course, that has not been well studied to date and is certainly to be determined. So anyway, thank you. I'm happy to think of other people's thoughts on their strategies and take any questions that I may be able to help with.
That was spectacular, Jill. Thank you tremendously. And once again, I'm going to be selfish and ask the first question. So I don't use bone turnover markers because I've always been taught, well, we really don't have any good norms.
Mm-hmm.
So can you just spend a minute or two telling me how you're using them?
So that is a great question. You're right. I think our norms are challenging. And then you throw in that kids and adults with OI, you know, affected bone probably makes it even more complicated. I will often use them as sort of part of the decision maker, as well as what's happening with their DEXA scan. So if it looks like they've suppressed dramatically, and that's really sort of challenging to tell because as they grow, what would have been normal will change. But I will use that as part of the decision making with the normative values that we do have. and look
And
at
which ones do you
so
find?
I personally use urine NT-lopeptides because I can get that easily at my own institution. And again, what I'm trying to do is decrease, make sure there's some escape basically from the oversuppression of osteoclasts is really what I'm thinking about. CT-lopeptides would probably be another good example. It's just something I can get easily. I'm often, if I can't get a urine sample, I may get a CT-lopeptide as well. But you're right, it's not the complete decision maker. Obviously, I will use DEXAs as well. And for those who have a part of their body I can evaluate by DEXA without instrumentation in there, then I will use that piece of information as part of it to either decrease the frequency, decrease the dose in conjunction with these other things.
Don't let me be selfish. Please, who
Matt, it looks like Matthew Warman.
all right,
Yeah.
Matt, speak up.
Hi. So, Jill, that was great. I want to ask you about your thoughts about the inclusion criteria for many of these studies, because the inclusion criteria make me worried. And I'll tell you why. I, I fell into the same trap. I published after Francis's paper, a bisphosphonate study years ago. And of course, we gave bisphosphonates to kids who'd recently fractured, and we showed a reduction. But of course, in OI, fractures are pretty episodic, and a child with type 1 OI can have a fracture 1 year and then have no fractures for 3 or 4 years, right? And the fracture they had is because their sibling pushed them down or they had a traumatic fall. So my concern, and you mentioned it as well in one of the studies, where they started the drug and then they saw no fractures for the next year. But of course, if the inclusion criteria is for recent fracture, and those kids with no therapy at all might have had no fracture for the next year, because of the nature of the disease, it's going to be very hard to show a true positive effect versus an effect from a faulty design.
I think that you're right. And I mean, I think honestly, it's sort of it's quite ambitious to think that fracture is the primary outcome regardless. I mean, we think about osteoporosis studies and it takes tens of thousands of patients, it seems like, to really show differences in fracture rate. So it's a bit of an ambitious outcome regardless. I think you make a good point. I think the alternative, though, is also the case that sometimes once kids get into a fracture pattern, they keep fracturing even more, right? And so, they get out of this cast and their balance is off because they've not been as mobile and then maybe their fracture does increase after they've had more increasing fractures. I think the other thing is if you argue, just for argument's sake, if you said, okay, well maybe they're having less pain, maybe their mobility is improving and now they're moving more and then they fracture more frequently. I think it's really hard to tell. So I think fracture as your primary outcome, although it's what we really want to see, something really definitive, because that's what largely we care about. It's really hard to prove because of all of those things that you said, and hopefully the things that I was thinking as well.
So I'll just mention we published a paper in Bone recently using a mouse model of OI that by 5 weeks of age has about 7.5 fractures. And we crossed it to a mouse model with the LRP5 mutation that works like romosozumab does, just increases bone mass. And those mice fractured 30% less. And what's nice about mice is fixed genetic background, fixed environment. They moved less with OI alone, and giving them increased bone and reduced fractures did not improve their mobility. And if you think of mobility in that instance as maybe being a surrogate for pain, but it may not be.
Right.
You saw no effect. And recently we've done the same thing for a mild OI mouse model. So this is a haploinsufficiency of type 1 collagen. And those mice move the same as wild type mice. And even the 20% that have fractures move as well as wild type mice. Now, again, mice are different than humans in that they're prey animals and they might move no matter what. But it still was sort of distressing and worrisome that if it's hard to measure pain in mice, think of how hard it's going to be to
Mhm.
really assess pain in humans too.
Absolutely. I agree. It's a really great point.
Thank you, Matt. That's terrific. Well, that was just great, Jill. I am going to keep us on time. But again, I'm sure, just let us know if you have more questions for Jill. I know she's a great correspondent, and we'll get back to you. I'm
Thank you.
volunteering you left and right.
Absolutely.
All right. And then last but not least, I'd love to introduce my colleague, Natasha Shore, who is going to talk to us. Our topic, their title is Clinical and Genetic Evaluation of Non-Accidental Trauma versus OI, and certainly a painful, painful topic in my own clinic. And I'm sure we are all having trouble with it. More families demanding genetic workup. And she's going to give us some great tips on how to manage all those questions. So Natasha, thank you so much
Thank
for being with us
you.
tonight.
Thank you. I really appreciate this opportunity to talk to all of you. I'm just going to share my slides. Okay, so we'll start at the beginning. And I was asked to speak to kind of how to separate fracture fact from fracture fiction. And I really appreciate all of you. I've been a medical geneticist for 20 years, and I've gotten to work with so many wonderful people, including Dr. Tosi. It's been such a pleasure to work with you, Dr. Tosi. And I know all of you, it's so fascinating the talk we just heard to talk that you discussed all these amazing treatments for OI. And of course, that's the impetus for making the diagnosis as quickly as possible in children who have it. And therefore, we always want to do all of the proper workup and diagnose the children that have it. But many times when children present, especially small babies, to the emergency room with fracture,
I'm
sometimes
sorry,
there's
real
this,
quick. There's
yes.
black boxes showing on your screen. I'm not
Oh,
sure what
I
they're from.
apologize. Okay, I think that's the
It might
is
be the
that
chat
away
box.
now? Thank you.
That one
Thank you
went
for
away. There's
telling
now
me.
one at the bottom as well, like a long one.
Oh, okay, here. Let me see if I can. Oh my goodness. That must be. Sorry, I don't know how to change that one. That's from the Zoom invite.
I think that's okay. I mean, the big one is now gone, so we can
Okay, thank you for doing that. I think that was
no
the other
problem.
people on the meeting. I had it on the wrong screen. Thank you. So the question always comes up, how do we truly diagnose these kids that have an OI, but also rule out trauma? And the main philosophy, of course, by Dr. David Chadwick, who is a pioneer in the field of CAPS, was that if inflicted injury cannot be proven to exist when it is present, children may be removed from the care of persons who may injure them again, sometimes fatally. If the diagnosis is made incorrectly, children may be removed from the care of their parents when that is not needed, and conceivably innocent persons could be convicted of crimes. Diagnosing child abuse is analogous to diagnosing cancer, and that the risks of overlooking the problem may be fatal, and interventions available after the diagnosis are invasive and hazardous. And so in the general population, we know that OI is about 1 in 10,000. In the fracture cases, there's actually a higher incidence, about 85 out of 10,000, sort of this slice. But unfortunately, abuse under the age of 1, when people come in with unexplained fractures, these aren't car accidents, these are just new fractures, there's kind of a 1 in 4 chance that it could be child abuse, sadly enough. And so there are a lot of fabricated theories, or what I call fracture fiction, and misconceptions in the media. And I've listed some of those theories, and I wanted to go through sort of, because we only have 25 minutes or less, the first 5. And one of those fringe beliefs is that OI is just missed all the time, that we really can't tell it apart on our radiographs. The second is that hypermobility, or classic EDS, which affects the joints, not the bone, causes babies to break. The third is temporary brittle bone disease. The fourth is that low vitamin D cannot be distinguished from rickets and cannot be distinguished from fractures. And the next that we're getting increasingly over the last 10 years is that genome on every fracture case is the solution. And I see a lot of genomes ordered on these cases. So I just wanted to go through really quickly these fracture facts versus fiction. So the first fracture fiction is that OI is missed all of the time. And there's this idea that because there are these 20 molecular types, there's no way of distinguishing that OI, quote, mimics abuse, and that there's no way to use clinical features or radiographs. And as I'd like to show you, there are only a few types, the mild types, that sometimes in rare cases, you don't see obvious radiographic features. As most of you know, when you see your children that you're diagnosing with osteogenesis imperfecta, you can tell by physical and radiographic exam in the majority of cases. And there's this idea that OI is this mimic, that it looks exactly like those cases, but actually with expertise, you can distinguish. And so I always tell people with every case, it's really important to be systematic and to really do fill in the box genetics histories where we look at the clinical history. So for example, one of my patients was a triplet with intrauterine crowding on day 6, had fractures discovered in 2 out of 3 triplets. And there had just been a few childhood fractures in the mom, a broken toe, and she was a little bit petite. Labs were normal, and growth charts in 2 of the babies with the fractures out of the triplets were lower. And then there was white sclera, but some bowing of the legs, and radiological findings showed osteopenia, thin cortices, and the molecular testing showed a pathogenic missense variant. What was unusual about this case, which was a mild OI, is that the mom had a very mild history, but because of the intrauterine crowding with the triplets, the 2 presented with neonatal fractures, probably in utero. But interestingly enough, even though I gave this mom an emergency letter in case the triplets returned, the 2 that did have OI never needed the letter and were mild in the end, like the mom. One of the key points that I always teach the lay public is that rare diseases have clear signs and symptoms, and the first step is really to look head to toe. And of course, all of you recognize these Wormian bones, and what we're really seeing is 10 in number. We're seeing them in a mosaic pattern. There's 6 times 4, and so you can really look at that as a major clue. And in the OI types, particularly even the mild types, a third of patients, and in the more moderate types, 3/4 of the patients, and in the severe types, almost all patients have increased Wormian bones. And of course, as all of you know, you're bone experts, there are a lot of other conditions that also have Wormian bones. So a Wormian bone, increased Wormian bones do not mean OI, but it is a clue we look for. And then the second key point is that to rule out a genetic syndrome, we consider not only what we see, but what we don't. And that careful physical exam, I won't explain to you what you're seeing in OI patients, is so important, but also the growth patterns really tell a story. And in type 1, people tend to be around 20th percentile. By the time you get to type 4, where people are more fearful that they're going to miss it in these young infants, you really should be seeing a decrease on the growth curve. Of course, every single condition is different in every family, but that would be another clue. Obviously, if you have super tall parents and a type 4 child, maybe it won't be as dramatic, but normally we do see that. And of course, you can tell the difference between the radiographs in a child abuse case and the one on the right, where you see that those thin ribs in the OI cases. And usually, again, in most cases, there is some clinical clue where you can really tell apart the OI on radiographs, like in the triplets that I showed you. And obviously, as all of you know, in the severe to moderately severe OI cases, it's very obvious on x-rays. And so you don't have to test for all the autosomal recessive severe types in a child where there are no radiographic findings, because obviously they would not have those autosomal recessive rare types. And same with type 5. I know that there are some concerns that this could be missed, but in the majority of those type 5 cases, you really are seeing, as all of you know, the calcification of the interosseous membrane, radial head dislocations, which I know can be difficult sometimes to distinguish, the hypertrophic calluses. And these radiodense bands here are actually from pamidronate therapy, but that's important. In the type 6 OI, which very rarely you can have a baby fracture and then develop the progressive deformities later, but an interesting clue is that the ALK phos levels are up because it's a mineralization defect, and it increases with bone turnover, and it tends to stay up, and often you'll see these multiple vertebral compression fractures, which of course are also in the differential for child abuse. But again, in the majority of cases with careful radiographic analysis, you can really see differences in the children that have high specificity for abuse fractures with those multiple fractures and various stages of healing, those CMLs, posterior lateral rib fractures are more associated with violent mechanisms versus in both child abuse and OI, there have been reports of anterior lateral rib fractures. Usually when you see fractures of the ribs, though, in OI, those are the cases that are severe enough that there's demineralization also seen. So it would be unusual in an OI case to see posterior lateral fractures without any radiographic evidence. And of course, all of you know the classical features in OI. And studies really have shown that in OI, the majority of parents, they bring their kids right away when there's a fracture, even in those mild cases, to medical care. They're like every other parent, worried about their child. And so most of the time when kids with OI come in to the emergency room, they have few fractures, not 10, 12 in various stages of healing like we more often see. Now, of course, in the severe or moderate OI cases, we do see more fractures, but I'm talking about those in the differential for child abuse where there's not an obvious OI diagnosis and it's a mild OI. And you'll see something in the family history or a clinical clue. So again, on a clinical basis, we're really looking for, is this a mild OI case that's actually in the differential when an infant presents with an unexplained fracture? And we would still be looking for those physical findings, that triangular face, blue sclera in 90% of the what we sometimes refer to as type 1 OI, and of course the demineralization in wormium bones. So the pretest probability for OI is actually quite high when it's present. Nothing is perfect. And so on to fracture fiction number 2, because I'm trying to go through quickly in 20 minutes. I could talk about OI with all of you for several hours, but there is this idea that has been raised over and over again in the media that that hypermobility or classic EDS causes fractures, and this has been found to be an alternative non-evidence-based explanation for child abuse, and it's been proffered by a few vocal cases. Basically, in every child abuse case across the country, there are people that testify that it is hypermobile EDS. So I did want to go through, is there any evidence for EDS causing infantile fractures? And when you look at the literature, you do see reports in adults who have lower bone density, because with Ehlers-Danlos syndrome, which is a disorder where you have joint hypermobility, a disorder of the glue, not the bone, sort of, people might have pain as adults. They might dislocate joints. And so that may cause less exercise. And so some people as adults don't exercise as much. And yes, some women have mild osteopenia. Some people have, even as adults, maybe a vertebral fracture or something like that associated with low bone density. But none of these people had fractures that, quote, mimicked child abuse. There was a really good study in 2006, and it compared all of these patients with classic EDS, hypermobility EDS, and did see a prevalence of osteoporosis. But again, it was just lumbar vertebral fractures in those that were gymnasts, divers, not babies. These people did not fracture as babies, and the literature goes on and on. But there was this pay-to-publish journal where one lead physician author, who was an editor of that journal, published a cohort where many of the infants in the cohort were not actually examined. and some had, quote, genetic testing, and they were referred often as second opinions in abuse cases. And many of them had fractures, very concerning for child abuse. And this hypermobility EDS was diagnosed based on a Baton scale. Again, not all of the children were even examined. 4% were said in the study to have a causative variant in SERPINF1, but apparently only one variant in some of those cases was found, but that's an autosomal recessive disease where you would need two variants. And reportedly, many of them had vitamin D deficiency, but it was not clear that there was true radiographic evidence of rickets. So unlike in that pay-to-publish paper that has been cited prolifically in all of the courts, the 2023 EDS guidelines really say that babies are hypermobile. Look at them, they're flexible. And so you don't really want to do a Baton score on babies. And they actually now say that because so many children are hypermobile, that you can say that they have joint hypermobility syndrome, things like that. Those kids aren't at risk for fracture, but you certainly don't even diagnose Ehlers-Danlos syndrome anymore in children under age 18. And so the AAP has concluded that another flawed explanation for fractures during infancy is an undiagnosed genetic disease like hypermobile Ehlers-Danlos syndrome. Again, this represents a false explanation for multiple infant fractures without evidence, particularly for syndromes such as hypermobile EDS, in which long bone and rib fractures are not components of the clinical disease presentation. And we really don't want our Ehlers-Danlos syndrome patients who have enough problems with some joint pain, maybe they've dislocated something, to think that they are going to have children and their children need treatment like in osteogenesis imperfecta, and are going to be scared that with routine handling, their children are just going to break. We really want to stop spreading that myth. So the fiction is that babies who have hypermobile joints break with routine handling. The fact is that gymnasts and swimmers, when you talk to them and you say, hey, did you break spontaneously as babies? They will tell you in most cases, unless they have a different disorder, no. Adult studies really shouldn't be extrapolated onto babies. These are different fractures, different populations. And the low vitamin D plus EDS together puts babies somehow over the edge is also a misconception that has been disproven. Most people, many people in general population, including me, have low vitamin D. I keep forgetting to take mine. But there's a big difference between that and rickets. Personally, I haven't ever had a fracture, and rickets do have obvious radiographic findings. And this low vitamin D alone is different than rickets, and rickets can be over and over again distinguished from fractures that are more suggestive of and concerning in infants for abuse. There's no pathognomonic fracture for abuse. It's all a very careful multidisciplinary evaluation together. But most all radiologists in a study could clearly identify signs in the arrows that are rickets and that this was different than child abuse. The fourth fracture fiction theory is that temporary brittle bone is osteogenesis imperfecta that goes away. This was proposed by Patterson and Miller, and there was this idea that multiple rib fractures and classic metaphyseal lesions could just happen, and there could be prematurity, maternal vitamin D deficiency, twinning, and it was temporary because it ceased when the child was in custody. But what is really interesting is that Patterson and Mole in 2012 wrote an article, and they said infants with findings consistent with temporary brittle bone disease were identified from clinical and medical legal referrals. Of 81 children in whom both parents had been examined personally, 40 at least had one parent with a Baton score of 4 or more, conventionally regarded as indicative of the hypermobility syndrome. So actually, this hypermobility theory is not so new, and it actually originated with the creators of temporary brittle bone. There's a direct connection historically between, and they're both kind of the same thing. Of course, a Baton score for somebody, for it to be significant, you need other features besides just a Baton score to have a diagnosis of Ehlers-Danlos syndrome, should be 6 or more. Four is something you would see in the general population, but this is the origin for the false EDS theory. So it's really important to consider standards of physician testimony, because our job is not to, of course, to be in a courtroom. Really, our job is to do the medical, to be systematic, and to really think about the child first and foremost, every case, every time. We don't have a side. Our job is just purely medical, and in the courtroom, we are educators of the truth. We're really supposed to just answer questions honestly. I know I had a case with Dr. Tosi where Dr. Tosi was rightfully very concerned about osteogenesis imperfecta, and an outside hospital thought that the case had child abuse, and Dr. Tosi spent many, many hours educating people about the extensive Wormian bones, the short stature, and the other findings that raised concern. And I was able to, of course, work with Dr. Tosi and also educate together with our multidisciplinary team, which did help in this outcome. And that child is safely with the parents again. So our goal is not to take a side and to say this is abuse or not abuse. It's really to look at a child's case and come up with a very careful multidisciplinary medical opinion. But unfortunately, there are some physicians that don't follow these standards of physician testimony. And so all that we can do in this OI group, it's so important for all of you to really educate that you can tell the difference in the majority of cases when it is osteogenesis imperfecta and when it's not, and people do present differently. And so we really need to make sure we always diagnose osteogenesis imperfecta when it's present, but we also educate people that the children with osteogenesis imperfecta do have features that in most cases, of course, there have been ones that are missed, sadly, but in most cases that raise concern. And so because so much of the diagnosis is careful, multidisciplinary, and clinical, genetic testing, that main idea that we speak about a lot is that genetic testing really should be used judicially after our clinical judgment. It's not some sort of necessarily safeguard or solution or needed in every case, every time when there's a clear, undisputed multidisciplinary clinical judgment. But across the country, in fracture, in hemorrhage cases, these tests are being used very differently. Some institutions send COL1A1 and COL1A2, the most common genes in osteogenesis imperfecta. Other institutions do a slightly larger panel. Still other institutions do these huge fracture panels or exome or genome. So this is a case, I had a case where a child came back with a variant in a fracture panel for Ellis von Creveld, which is also an autosomal recessive disorder, but it was one variant, and that was very confusing to the courts. But actually, Ellis von Creveld looks like this beautiful child here, with extra fingers and a short thorax, and you would have seen two changes, not just one, but it caused a lot of confusion. So sometimes these fracture panels that have disorders like Ellis von Creveld, when that's really not in the differential for the child at hand, can cause confusion. And then still other places do no testing whatsoever. And again, if you have a baby that presented with maybe one fracture, that might be a very good candidate to do a limited OI panel on versus a baby that necessarily presents with 10 fractures, multiple stages of healing, and many other concerning things, bruising and all sorts of things, and then gets a genome. That would be an inappropriate use of testing. So we really want to think about which disorders are truly in the differential, and if they're not in the differential because they have much more severe presentations, then they really don't need to be tested in every single fracture case. And so I have highlighted a few of the disorders that could be more mild and may not have as obvious findings. And that might be appropriate in some cases for a genetic testing panel, but it doesn't mean that every single disorder should be tested. And I just want to say that we've had this huge evolution. I'm not going to go over every test over the decades of testing, where now genome is coming up more and more commonly. And Genome really detects many, but not all of the categories of genetic disorders, but again, is not necessarily useful in every single case. And there are some courtrooms where they're sending these, quote, molecular autopsies on patients who've died of multiple injuries, or they send these, quote, molecular autopsies in child abuse cases. And what can happen is that they can come back with many different variants. For example, in this case, where the multidisciplinary medical team diagnosed abuse, there was this SERPINF1 variant that came back. It was in an autosomal recessive disorder, but because they read likely pathogenic, even though there were not two changes present, there was only one change present. It really confused the case. And hereditary hemochromatosis is an adult onset disorder, but the defense witness in the case said that this had caused the liver damage. And it can also come back, genome testing with these and exome testing with incidental findings like this ALS gene, which was inherited from one of the parents. And we really don't want that complication on an infant. And variant classification is a very multi-step process that does require some expertise when a variant of unknown significance comes back. And we really need to think about our pretest probability, search the databases, consider the inheritance pattern. Parental testing is not always available, but if a parent has the same variant as a child, but no fractures, no symptoms whatsoever, we really think the variant is less likely to be contributing. And so in this particular example where genetic testing was used, it would still not necessarily change your pretest probability. But I just want to point out that genetic testing in and of itself is not a cure and can be a complication, causing confusion or misdiagnosis, over-medicalization, home placement. We want to use these tests when it benefits the child. And so our goal is to always do a very careful, systematic review, summarize the case in great detail. And if the disorder is in the differential, look at the natural history of diagnosed patients and compare to your baby in front of you and really consider the benefits versus risks of the child before ordering a test. Because genetic testing is usually not an emergency. It takes a while, and doing the good clinical care is what we love to do. This is just my slide to remind myself to thank all of you, and of course, Dr. Tosi, who's so fun to work with and has such incredible expertise, one of my heroes. And that's my son. We were hiking in Colorado and Peru, one of my favorite things to do in this world. And I hope you have a wonderful evening, and I'm happy to answer any questions about this.
Terrific and right on time. This is great. We're open to questions. We always have some difficult stories here. I'm particularly grateful that you brought up the EDS issue because you're right on target. I've had several of those cases come my way recently, and I really appreciate the armament you've now given me, because there are a number of people in the area, our area, that are supporting that. And I would ask you, is there a specific manuscript you feel is a good thing to refer to, you know, as you're writing it up?
I'll send it to you. So the best is the AAP latest guideline.
Okay, great.
And that language is right in there. And it took a long time for us to get the language into the guideline. It was amazing, like 10 years, but it's in there. So we're very happy. And I think it's going to be helpful to people because this really is just a spin-off of temporary brittle bone. And I don't, and it's hard, it's distracting because, as you know, we do really want to diagnose those kids with OI and we don't want to miss them, but we also don't want to get distracted when a child is sadly presenting with injuries.
Absolutely. Absolutely. To our audience, please feel free to unmute.
Thank you so much for this talk. It was really helpful. I wonder if you have any thoughts or guidance for how you respond to parents who end up in your clinic for an evaluation for OI in the setting of old fractures without recurrence who have been reassured by one example I saw was a patient who had fractured at 6 months of life, and when the case went to court, an adult radiologist was paid by the defense team to testify that the child had rickets. Um, and so walking back the diagnosis of rickets, which the child clearly didn't have, as you stated, based on radiographic findings, are there any ways that you are able to reassure the parents and kind of reframe for future guidance so they aren't worried that their child might develop rickets or temporary brittle bone disorder or something similar based on bad information that they've been given?
Yeah. So I really just do the same thing as I do for all my other patients. I do the same history, the same family history, the same physical exam. Then I look over all the previous notes and the radiographs, and then I just tell them that there's no evidence here that there's been a genetic disorder. That's such great news. I'm really happy that your baby is healthy, and we need to focus on the healing and all these wonderful things. So then I'll reframe the discussion to focus on all of the positive, wonderful things we can do for the child at hand. We never know when there has been an injury to a child. I don't know that it was, I've seen really tragic cases where it was a baby died. There were two mothers who kept going to the pediatrician with bruising, and then the baby was killed. And the pediatrician said the mothers were nice, and they were nice. It was the daycare provider. So we never know if the people bringing the baby were the people that actually, if there was a clear diagnosis of abuse, who.
Absolutely. Yeah,
That's not
absolutely.
our job. So instead, we just really focus on this is not genetic, great news, and keep reinforcing that message.
Okay. Thank you.
Yes.
I think the challenge personally is when it's the grandparents showing up because the parents are in jail.
Yeah.
Desperately to get their kids out. And yet they're coming with this EDS or other story that clearly I'll have to agree with, and I can't. This is not easy.
It's not, but it's so nice that there are people like you with such expertise and honesty, and it really makes all the difference because that's the best we can do.
We have time for one more question. Anybody want to pipe in?
Hi, I'm Wei. Actually, I just want to hear your thought because sometimes in nursery in NICU, we often has a very small premature babies who has accidentally found to have fractures. And then so after very extensive workup, we found that this baby also has caught findings of a vitamin D deficiency. But from skeletal survey, we can't really determine like if the child has any genetic disorder. So like often like this time when we dealing with these situations, sometimes the neonatologist will just conclude the case as fractures due to vitamin D deficiency. Like I just want to hear from you, like how more extensive will you work out? Will you go to do genetic testing, like to say this is absolutely just osteopenia of prematurity, this is just a vitamin D deficiency?
Well, the ones that have true vitamin D deficiency, like vitamin D receptor deficiency, that's rare, or hypophosphatasia, it doesn't just correct with some vitamin D, because if the receptors aren't working, it's really severe. So if you have a baby with prematurity who had vitamin D deficiency and you give them vitamin D and it corrects, then those are very unlikely with just some vitamin D, those are unlikely to be the genetic kind. The genetic kids, like I said, I've seen only a few where it was a true genetic vitamin D receptor deficiency, and threw a lot of vitamin D at them, and their vitamin D was extremely, extremely low. So that would be my signal to really worry about the genetic vitamin D ones. Now, of course, hypophosphatation, all of that is a different story.
Thank you.
So thank you everybody for your participation tonight. Just great to have such good attendance. I wish everybody a wonderful Thanksgiving. We're always open to what topics you want to hear about. So please, please, please be sure to reach out to us as we start to plan the spring meeting, which we'll be announcing in the spring. So happy Thanksgiving. Thank you for being here. And I look forward to seeing you in about 6 months.
Thank you.
Good night. And thanks to my speakers, of course.
Thank you.